and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Gaurav Prakash from PGI Chandigarh, our chief guest for the day, Dr. Seema Bhatwadekar from Vadodara, all discussants and participants to this virtual symposium on Venetoclax in AML induction therapy, current evidence and evolving perspectives. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the edges of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a senior hematologist and bone marrow transplant physician from Surat in Gujarat. Dr. Amit has many publications to his credit. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Gaurav Prakash from PGI Chandigarh, and he's going to lecture us on Venetoclax in AML induction therapy, current evidence and evolving perspectives. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Zydus, Natco, Lucien, and Unipath, and very well managed by Perfect Square. I thank Team Zydus, Natco, Lucien, and Unipath, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Seema Bhatwadekar from Vadodara, our guest speaker for the day, Dr. Gaurav Prakash from Chandigarh, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 17th of January 2026 from 7 p.m. Indian Standard Time and 7:30 a.m. Central Standard Time, we have Dr. Stephen Ansel from Mayo Clinic speaking to us on management of Hodgkin's lymphoma and update from ASH 2025. And the following day, that is Sunday, 18th of January 2026 from 11:30 a.m. Indian Standard Time and 5 p.m. Melbourne time, we have Dr. Ashish Bajil from Melbourne, Australia speaking to us on optimizing treatment of Ph-positive acute lymphoblastic leukemia. Let me introduce our discussions for the day, and they are well displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day for very eminent hematologists, hemato-oncologists, as well as medical oncologists all across the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We are no other than Dr. Gaurav Prakash from Chandigarh. Let me introduce Dr. Gaurav Prakash to all of you. He is MD in Medicine, DM Medical Professor, Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. He is a professor. Gaurav Prakash did his MD in Internal Medicine from PGI Chandigarh. This was followed by DM in Medical Oncology from AIMS New Delhi. He has done observership in BMT from Cleveland Clinics, Ohio, USA, way back in 2015. BMT in immunodeficiency disorders from Children's Hospital, Los Angeles, USA in 2015, and medical oncology from Corgetown Hospital, Washington, USA in the year 2012. He is a recipient of IDEA, that is International Development and Education Award by American Society of Clinical Oncology in 2012. He has received innumerable other awards and distinctions during his academic career. He is a member of various distinguished hematology and medical oncology societies and associations. He has published peer-reviewed articles in various national and international journals of repute. In addition, he has also written chapters in various books and monographs. He has participated in international conferences and presented oral as well as poster papers. Today he is with us and is going to lecture us on Venetoclax in AML induction therapy, current evidence and evolving perspectives. But before he does that, let me introduce our special guest and chief guest for the day. We have no other than Dr. Seema Bhatwadekar from Vadodara. Let me introduce Dr. Seema Bhatwadekar to all of you. Dr. Seema Bhatwadekar is hematologist and oncohematologist at Hemato-Oncology Cancer Care Center, Vadodara. She did her MD in internal medicine from Gandhi Medical College, Bhopal in 1991. She was trained in clinical hematology and bone marrow transplantation at very prestigious Sahyadri Hospital, Pune from the year 2004 to 2006. She is the program director for Hematology Update Vadodara, which is an annual CME organized at Vadodara since 2007. She is also the vice president of Hemophilia Federation of India, Vadodara chapter. She is a life member of ASH, ISHBT, API, and IMA. She has publications in various peer-reviewed national and international journals. It's my privilege to welcome Dr. Seema Bhatwardekar to inaugurate a webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Seema Bhatwardekar.
Good morning, all. It's indeed great pleasure and honor to be a chief guest of such a prestigious meeting. And all of you know that MHG webinar is an amazing educational activity which is free for all across the India and across the globe. And it's not only useful or beneficial for all the postgraduate students across the country, but it's very beneficial for the private practitioner also. In fact, what I feel is if anyone is not able to attend national or international uh, hematological meeting, hemat-oncology meeting or transplant meet, just attend these seminars, webinars every Saturday, Sunday, and you are done with it. So your knowledge, basics, as well as updated will be up to the mark. And for this, we are all of us are indebted to Dr. M.B. Agarwal and MHG for providing us such an amazing educational activity free for all across the country, across the globe. And I'm sure today also all of you will get benefited with a lecture on Venetoclax. Over to you, Amit, to proceed today's meeting.
Thank you, Dr. Seema ma'am, for wonderful, wonderful words of wisdom. And thank you for accepting us as our invitation to join as a chief guest for the day. Thank you so much, ma'am.
Thank you.
And now, Gaurav Prakash, the screen is yours. Please go ahead.
Give me just a moment's time. Can you see my presentation?
Yes, but we are not able to see in full screen mode.
Full screen. No, just give me a minute.
Just make it full screen mode.
Yeah. Is it okay?
No, not yet.
Not yet. Okay. Can I email it to you and you can just upload from there?
You can email to Nikhil. Nikhil, can you please check your email? He's emailing you.
So I'll send you the email address and just
Yeah,
send.
can you just send an email hi and I'll
Yeah.
reply to you.
You got my email? I'll just send you in the chat box.
Oh, okay, fine. Yeah, got it. Make up for this gaffe by trying to help the audience with this. Thanks everyone who has joined across the country and the globe on this Sunday morning. So the field of AML has shaken up in last 4 and 5 years. It will not be an overstatement to say that, and I'll show you how. So I have no financial disclaimer, and any proprietary name in this presentation will be only illustrative. So let me start with a South African proverb. Knowledge is like a lion. It cannot be gently embraced. And this is exactly what is happening in the field of AML. Whenever something has been around for decades, it becomes a norm. And anything which comes up which is new, is never accepted easily. But then, if that new knowledge is true and is strong like a lion, it will conquer. And I believe this is going to be the case with Venetoclax in the field of AML. Right. So let us start with three statements. All of us will agree with them. Number one, AML is the most common acute leukemia in adults. Number two, it is also the most challenging one. And third one, our treatment of AML is stuck in the past. Why? I will just illustrate this paper from 1973, which is published in British Medical Journal. And this was the first paper with 3+7, Management of Acute Myelogenous Leukemia. 1973, pause for a moment. And, now we are in 2026. Luckily, some changes are appearing, but I think till 2020, it was 3+7 or nothing. So I will bring you to the treatment which has been happening till recently. Now, if you talk to any oncology, hematology teacher or read any guidelines, how will you take a call on AML? You will immediately answer that, sir, I will have a look at what is the cytogenetic profile of a patient, what are the risk factors, what does the NGS report says, and according to that, we will see the algorithm and decide. But I will be brutally honest with you. In 95% of the situation, in day-to-day practice of oncohematology, we do not do so. How do we decide? This is the brutal truth. We assess whether the patient is fit and rich, or patient is old but still rich, patient is fit but poor, or patient is old and poor. How much we dislike it, but this is the reality as far as AML management in India or other developing countries is concerned. Now, starting with the fourth block, if the patient is old and poor, then treatment decisions are not that difficult because there are no decision to make. Most of these patients would go on best supportive care or maybe some kind of low dose oral therapy or something like that. So that is one sphere where we till now had nothing much to offer. But in the other three groups, let us have a look at it. So if the patient used to be fit and rich, means affording, then 3+7 or similar induction regimen like FLAG-IDA and the variation of the same were the frontline therapy, followed by stem cell transplant if needed. If the patient was older but still affording, then hypomethylating agent with or without gemtuzumab or zugomycin, or in some brave situation, abbreviated 3-7 in the form of 2-5 could have been our option. The situation was most difficult when you had a patient who is fit but not very affording. So in those cases, definitely you can't leave the patient untreated. Various combination dosing up and down between hypomethylating agents, subcutaneous Araci, 2+5, or only some support, sometimes only supportive care. So this is how we used to decide, and not only used to decide, we decide and treat these patients. Yes, we do send genetic biomarkers, cytogenetics, but they take time to come. On day one, the decision is based on this. And with this kind of treatment, if we have a look in the history, this is what decadal trends in AML look like. The lowermost graph is brown one is before 3-7. So we can easily forget it. But if you see after 3+7, every bar is 1 decade. Every line graph is 1 decade. So although on an optimistic side, you can see the median survival has doubled from this bar, which is 80 to 90s, to 2000 to 2010. Median survival from 11 months to 22 months. But the kind of developments we have seen in other malignancies, other hemat tumors, this is less. Second thing, the change is mainly seen in younger population. The graph on this side is of older population, where almost all the graphs across all past decades appear to be overlapping. Now, you will agree with me when I say that this increment in survival in younger individual has been largely the result of better supportive care. We have better antibiotics, we have better antifungals. So we are able to treat fungal infection, other infection, gram-negative severe infection in a much better way. Therefore, it has contributed to increased survival rather than any spectacular development in the field of oncotherapeutics as far as AML is concerned over last these 4 decades. So that gives us a very humbling humbling experience as well as an opportunity to improve upon. So I'll just say all of us have seen this movie. This is a very large, huge empire on which for last 4 decades, one emperor has ruled. A very strong emperor, intensive chemotherapy, and no other therapy could, kind of challenge this rule. But of late, the title of my talk is the same. The person who challenged this emperor was a princess. Venetoclax, which we all know, it is a small orally available molecule and which is a selective but highly specific inhibitor of BCL2 protein. In order to understand venetoclax in a better way, let us have a very simplified look at apoptosis. Now, apoptosis, you can see we can divide in 2 columns. One is pink, the other is blue. The pink one is pro-apoptotic protein. These are the proteins which sensitize or facilitate apoptosis, right? And this is the dominant force in our health. Because in our health, we want that all the cells which are unwanted, cells which are dying, they should die in a proper fashion and undergo apoptosis so that new cells can come up. The blue column, on the other hand, is anti-apoptotic proteins. And at the top of this list, you can see a B cell lymphoma protein 2, which is BCL2. Now, most of the time, many times students ask me, sir, it is counterintuitive. BCL2 is, associated with low-grade lymphoma and CLL, and the name itself is a lymphoma protein. How come it is active in AML? We will have a look at it. So you can see that BCL2 can inhibit the pro-apoptotic protein, and by inhibiting pro-apoptotic protein, it gives survival advantage to any cell. This is in general two-tower model of apoptosis. Now, if you see what is the relationship of AML and BCL2, so as I told you, the primary function of BCL2 is to protect a cell from apoptosis. And for some reasons, BCL2 protein is commonly overexpressed on AML blasts. Most of the AML blasts carry BCL2. So this overexpression of BCL2 over AML blast render them safe from apoptosis. So it gives them survival advantage. So BCL2 positive AML blast have survival of the blast as well as leukemic stem cell. As a result, it is associated with poor prognosis. A pictorial diagram is showing this green one is a BCL2 protein, and when it is overactive, it quenches the pro-apoptotic protein. So this pink protein has ability to induce apoptosis, but BCL2 has held it closely. Since BCL2 is active and it has held the pro-apoptotic protein, the cell, which is blast in our case, will not die. Now, when you give a drug, which is Venetoclax, which also binds on the same site in a BCL2 molecule, it releases this pro-apoptotic protein, and as a result, pro-apoptotic protein goes to mitochondria, and through cytochrome C pathway, it induces apoptosis and our AML blasts die. So this is exactly how a very small molecule called Venetoclax is active in BCL2 molecule and AML cells. Now, because we are discussing Venetoclax at a length, let us have a peep into the development of Venetoclax for AML. We all know Venetoclax was developed initially for lymphoid malignancy, mainly CLL. But if you see the development, the first drug which came into clinical activity was Venetoclax. It was quite active. It was first oral inhibitor, but it was associated with severe thrombocytopenia. So further development was dropped. It was not clinically usable. So scientists decided to develop something similar, which is called Obitoclax. It is a different molecule. It has a better binding with AML blast and BCL2, but efficacy on AML cell lines was not seen. So it was also dropped. So after this, scientists went back to Venetoclax only, and they modified it in such a way that it became effective as well as with reduced incidence of thrombocytopenia. And the molecule was ABT199, which is we better known as Venetoclax. Now, Venetoclax, when it first came CLL, it was very efficacious in the form of monotherapy. So therefore, in AML also, it was tried as monotherapy in a phase 2 trial in relapsed refractory AML patient, but it was not efficacious. The overall response was only 19%, and the duration of response was only 48 days. Only 1.5 months patient could sustain that remission. So as a single agent, it was a failure in AML patients. So therefore, scientists thought single agent it is not working. We need to do something else, and they started to look for a partner for Venetoclax. And luckily, various early phase studies has showed that number of drugs can improve outcome of Venetoclax in AML. And in this exhaustive list, if I draw your attention to the initial part, so you can see our very familiar drug like daunorubicin, cytarabine, azacitidine, panovinostat, all of these are clinically available, are a potentially synergistic partner with Venetoclax. And towards the end, you can see the newer kits on the block like quizartinib and inacidanib, both FLT3 and IDH2 inhibitor, respectively. They are also synergistic with Venetoclax. And we will see, some of these molecules in the subsequent parts of my presentation. So this is our first combination phase 1 study of azacitidine with Venetoclax. And this is the famous, Dr. DiNardo became very famous because he led this work and multiple similar works from MD Anderson. And this led to accelerated approval of Venetoclax in combination with azacitidine for AML in 2018. There were 2 publications and it showed really promising results. And I think this is one of the very few instances where an anti-cancer drug is approved only on the basis of phase 1 data, phase 1, phase 2 data. And this shows the desperation not only in the doctors, but in regulators also to find something which is more efficacious than a standard cytotoxic chemotherapy or the erstwhile treatments for AML. So that is a story. And we have come from development to 2018 and Venetoclax was approved for elderly and unfit patient. But the pivotal points for Aza-Ven combination came in 2020 with these 2 trials, and you both are aware of the same. Wiley A trial and Wiley C trial. This famous NEJM publication, which kind of shaken up the field. We will discuss both Wiley in detail, but while C, I will just touch upon it. While C is Venetoclax in combination with low-dose Ara-C. So it was a randomized trial, good number of patients, 210, and they were randomized in 2:1 ratio. In one arm, low-dose Ara-C was given with Venetoclax in comparison with only low-dose Ara-C. It was an open-label study. The investigators found that there are higher CR rate with the combination of LDAC and Venetoclax. However, the overall survival benefit was marginal and it was not statistically significant. In a pictorial view, you can see around 211 patients were randomized, 142 in the combination arm, 68 only low-dose Ara-C. And if you see efficacy, yes, combination led to higher survival, but the survival was not statistically significant. So therefore, with these modest results, the interest in low-dose Ara-C and Venetoclax slowly died down. And at the same time, more remarkable results were noted with combination of azacitidine and Venetoclax. Wiley A, the famous study, was again a phase 3 open-label RCT. Its primary endpoint was overall survival, and multiple secondary endpoints were there. Now, if you see, most of us have this belief that Wiley study was mainly for old individuals. Yes, indeed. Older individuals made the majority of the proportion of participants. But if you see in this inclusion criteria, any patient who was aged more than 18 years or with some kind of comorbidity could have been a part of Wiley study, and patient with ECOG 2 and 3 were also included. Now, just imagine your clinic or your hospital. What is the average PS of a newly diagnosed patient of AML? In public sector hospital, I can tell you most of them come with a PS 4, 3. Some patients come with PS2. So that means most of the patients that we treat in India are already a part of the population of Wiley study. That is a very important point to keep in mind. This study was also randomized 2:1. Now, the therapy was simple. Venetoclax was rapid ramp up, day 100, day 2 200, day 3 400. And afterwards, continue 400 mg for 28 days. As azacitidine was standard 75 milligram, it could have been given IV or subcutaneously for 7 days consecutively. On the other side, we have placebo along with azacitidine, which has to be given for 7 days. So let us see the results. The complete response rate was like more than doubled, 66% versus 28%. If you see a population with TP53, only azacitidine, there was no CR, but if you give aza-ven, CR rates were 55%. Similarly, secondary AML with myeloid-related mutations, they all showed higher CR rates. The icing on the cake is number of MRD negativity achieved with aza-ven. While single agent aza led to only 7%, 7.6% MRD negativity, the combination led to nearly 25% MRD negativity, which for an oral drug in combination with a hypomethylating agent is a very remarkable number. The median duration of CR was also higher in combination with aza and venetoclax. These good results also reflected in survival, and you can see there was significant improvement in survival, 34% reduction in mortality. So you can see this is only azacitidine and this is aza with ven. This is a short-term follow-up. If you see long-term follow-up, the gap between single agent azacitidine and HMA ven combination is sustained even after long follow-up. So this is the relatively recent paper on long-term follow-up. Now, next question will come, what is the safety of this? So you can see safety. If you see adverse event, all types of adverse event which were grade 3 or more, as a Venom, 99%, only as a 97%. But some mentionable, honorable one were like infection were slightly higher in patient who received combination. Thrombocytopenia, neutropenia, and febrile neutropenia all were higher in patients who received combination. Dose interruption as a result were also higher in patients who received aza-ven combination. However, the saving grace was that 30-day mortality was almost similar in both the groups. So you can see in this Wiley study where they use maximum dose of venetoclax 400 mg, it was more toxic, although it did lead to better results in comparison to azacitidine alone. Now, if you see the subgroup analysis of Wiley study with respect to MRD, so you will realize there is a huge gap between those patients who achieved MRD negativity with aza-ven combination. This is a green graph. In comparison, there are patients who were MRD positive, the blue graph. And if I put these two graphs in number, the MRD negative patient subset median OS was nearly 3 years. If even after aza-ven MRD was positive, the median survival was only nearly 1.5. So almost half or double, you can say. So this will come again and again. The impact of MRD is going to be much higher in times to come in AML, especially in those patients who are treated with aza and ven combination. This is a subgroup analysis, no need to read. I just wanted to show that across the board from different variable profiles, the treatment is favoring aza-ven. Only two mentions, the patient who have TP53 mutation and FLT3, the classical high risk AML. In them, in a subgroup analysis, the confidence interval was crossing the unity line. So therefore, that has to be kept in mind. Now, with this data, phase 1 data, while E study, while C study, what we can conclude that Venetoclax is effective in AML. But question comes, is it effective for all AMLs across the board or not? So with this, I will introduce impact of genetics on response to Venetoclax. Now, this is a very nice paper in which they have, again from the same group, Dinardo et al., in which they tried to see the impact of AZA-VEN in different genetic subtype like favorable risk, intermediate risk, or unfavorable. So they said that if the patient is having NPM1 and IDH2, then they are going to have exceptionally good outcome, 80% plus complete remission rate and 70% overall survival at 1 year. In comparison, the patient who harbored these mutation did poorly, and only 37% of them survived the first year. And you can see the Kaplan-Meier survival graphs are here. Now, another group reported similar data. This is from Gangat et al. And they found that apart from NPM1 and IDH2, it is DDX42 mutation also, 41, which is high, which makes AML patient highly sensitive to Venetoclax. Similar results are in 82% CR rates and 71% 1 year survival. On the other hand, those patients who did not have these mutation, the survival was very poor and humbling, less than 50%. And you can see these are the patient, yellow is a patient with these mutation, and the lower two graphs are almost overlapping, who did not have those mutations, rather had these poor risk mutations. So now we are learning that AZA-VEN is effective, but it is not effective across the board in all AML. Certain genetic subtypes get higher benefit with this combination. This point was further addressed in this paper published in Blood last year. Now, they have enumerated multiple mutations, and if you see mutations like NPM1, core binding factor, the classical good risk, they have excellent CR rate, 80%, 90%, 93%, 96% or so. The mutation like IDH1 and 2, which are otherwise poor risk or markers, but with respect to Venetoclax, they also showed very good response. The only translocation 821 was the one which showed a poor outcome, probability of CR only 40% with combination of azacitidine and Venetoclax. So this table is table with good treatment outcome. The other one is this is a set of mutation which showed relatively poor outcome. Mainly honorable mentions are these one, TP53 and poor risk cytogenetics, various other TP53 mutation, and RUNX one, where the CR rates were around 50% or lesser. So now we are seeing a clear divide. There is one subset of patient where we are getting CR rate in 80s and 90%. There is one subset like translocation 821 and TP53 and RUNX1, where we are getting complete remission rate of 30 to 50%. So going forward, we are going to see better genetically driven prognostic models which can guide us in using Venetoclax in a better way. Right. So I think till now we are somewhat convinced that Venetoclax is effective in AML. Venetoclax can be delivered in combination with AZA-VEN, and we also know there are some subsets of AML which show very good response and survival with Venetoclax. The next question with which the entire field of hemato-oncology is grappling is a dose conundrum of Venetoclax. What is the right dose of Venetoclax for AML is a big question mark. And it started because of a faulty design by the initial investigators. Again, the same Dinardo et al. So let us have a look in the story of development of Venetoclax again from a clinical point of view. Dinardo et al. Performed of this phase 1 trial on which they got approval, and it was phase 1b study, and they started from 400. So this is something which is very amusing. I will show you in the next slide. Anyway, after starting from 400, they kept on going up to 1200 mg. And after having done this phase 1 trial, they came back again to 400 and said, okay, fine, this is our final dose. Now, this is why it is so worrisome and why did it created so much confusion that we all are now grappling with the right dose of Venetoclax is because of this pharmacological debacle. The pharmacological debacle, to understand it, we have to go through the process of drug development of a phase 1 study. Any phase 1 study has an escalation cohort and an expansion cohort. Let us have a look. You have to start in an escalation cohort with a very, very small dose, and then escalate the dose like 10 mg to 20 mg, 20 to 30 or 40 mg, and so on, till you start to get significant toxicity. And after that, you expand that cohort in further number of patients to be sure of your results. This is how we do it. But if you see in AML, Dinardo et al., they just borrowed 400 mg, which was the top dose for CLL, as our base dose for AML. They completely forgot that in CLL, we use Venetoclax as a single agent. They also forgot that in CLL, patients are fitter. The extent of cytopenia is not as severe as in AML. The extent of infection is not as severe as AML. They just copied the same dose. And at the same dose, they added another very toxic drug, which is hypomethylating agent. So as a result, this can be called as a faulty design. They would have been better if they had started with a really low dose of venetoclax, because they were adding it with an hypomethylating agent as a cytidine, which is also very, very myelotoxic. So this led to confusion that 400 mg is too much. We are seeing so many cytopenia. So what are the other dose schedule or strategies that we can use to optimize use of venetoclax with HMA? The first strategy is going low on the dose of venetoclax. That means we go low on venetoclax from 400 mg, we come down. The second strategy is we go low on the number of days of venetoclax exposure. That means rather than giving it for 28 days, we give it only for shorter duration of days, and we will see in subsequent slide. So first strategy, going low on the dose of venetoclax, and we adopted this strategy and we performed a research on reducing the dose of venetoclax and seeing the outcome. So I will present to you our research paper, which is published in Leukemia and Lymphoma. We compared response rate of venetoclax 50 mg with posaconazole along with venetoclax 400 mg administered with amphotericin B. We titled this "Less is Enough," and indeed we proved that less is enough. In this study, it was a cohort, non-randomized cohort study. In first cohort, patient received standard venetoclax 400 mg. We gave it for 21 days with amphotericin B. In the other cohort, patient received only 50 mg of venetoclax, again 21 days, but this was given with posaconazole 300 BD. Now, when these cohorts were followed up, so you can see in green, we have venetoclax 50 mg low dose. In gray, we have full dose 400 mg. So if you see CR rate, if you see overall response rate, and this graph over here is MRD negativity rate. So all these parameters are almost neck to neck between 400 mg and 50 mg. More so, we did a very nice pharmacokinetic study. The AUC 0 to 24 data clearly shows that these results, similar result between 50 and 400 mg, were achieved with much lesser exposure of drug when we used 50 mg of venetoclax. This is area under the curve. You can see AUC is very high for 400 mg, but low for 50 mg. And even then, the clinical outcome with 50 mg venetoclax were at par. Similarly, further, deeper pharmacokinetic parameter also showed the similar values. So what we concluded by our experiment in our study is that when 50 could achieve comparable CR rates and MRD negativity rate as when 400, PK study showed that when 50 can achieve similar responses with much lower exposure to the drug. As a result, when 50 was less toxic, we did not have any grade 3 and 4 toxicity with when 50. And when 50 cohort had faster neutrophil recovery, 17 days versus 24 days. So this was our summary. FDA also seems to be agreeing and watching our work, and they have recommended that if you are using posaconazole, the recommended dose of venetoclax is 70 mg. And not only 70 mg, they have in the notification, they have said dose reduction below FDA guidelines of 100 or 70 mg may be important for managing cytopenias in Wiley study population. And they used voriconazole. So therefore, it becomes very, very important that we are very much careful about venetoclax dose. And for AML, less is more. Now, from low dose, reducing the dose, let us move to second strategy of improving venetoclax outcome. That is, go low on the number of days of venetoclax, while a study used 28 days. In PGI study, we use for 21 days. I will show you data on 14 days and 7 days also, and then I will leave it to you to decide that which one is more appropriate. This is a study from France, the 7+7 regimen. Very interesting design. They gave 7 days of azacitidine and only 7 days of venetoclax per cycle. It is a retrospective study. So they found 82 patients in their cohort in France, and they borrowed data of 173 patients treated in the US. And in US, they were treated full 21 to 28 days cycle. So it is like across country retrospective comparison only. They found that when they used only 7 days of venetoclax, there was no difference in CR rates with their French cohort in comparison to the US cohort, which was treated with 400 mg for 28 days. Rather, they said that 7+7 group had lower platelet transfusion requirement and lower 8-week mortality. Obviously, when some of us can ask, this is a retrospective across two countries, uncontrolled comparison. That is true, but I think this is a real world situation. They gave just a impression for us to think and design better trials, that even 7 days of venetoclax is leading to comparable CR rates. That is a food for thought. Similar to French, Japanese also compared giving venetoclax for 14 days versus 28 days. They concluded that shorter duration of venetoclax, even for 14 days, was equally efficacious with better safety profile. So they almost, showed what French showed. French people said that 7 days is good enough. Japanese are saying, okay, 14 is also good enough. And this is a small study. In patient who received 14 days of venetoclax, there was low febrile neutropenia, reduced duration of hospital stay compared with full dose venetoclax group, and same CR rates. So now you can see in two geographically different populations, Japan and France, they demonstrated that lowering the number of days is feasible. Now, USA can never be far behind. So they compared 3 types of schedule, giving venetoclax for full 28 days, 21 days, or 14 days, in combination with azacitidine in newly diagnosed AML patients. Now, in this good study, 270 patients from Mayo Clinic, the HMA partner was either decitabine or azacitidine standard doses, but venetoclax 3 different doses were tested. And the decision of using which schedule was completely based on physician's choice. It was a randomized, non-controlled trial. Now, if you see among all these 3 schedules, the CR rates were similar, almost in the range of 60%. The MRD negativity rate was similar, but it showed higher trend towards longer duration. 28 days had numerically higher MRD negativity, but obviously the difference was not statistically significant. Furthermore, in this study, they have noted that toxicity was also numerically high in patients who received 28 days of venetoclax. But again, it was not statistically significant. As overall survival between 14 days venetoclax, 21 days venetoclax, and 28 days venetoclax was almost similar, rather numerically higher in patients who received venetoclax. So what can we conclude from these 3-4 trials I showed you and our own experiment at PGI, that a lower dose or a lower duration of venetoclax both can be used without losing efficacy, and we can gain on the front of lesser toxicity. So I think more and more people are becoming convinced that venetoclax, number one, can be used in upfront setting, and it can be used at a lower dose or lower schedule with lesser toxicity. The same is reflecting in the practice in our country. The slide credit of this slide goes to Dr. Smita Kayal and Dr. Uday Kulkarni from Hematology Cancer Consortium Group. And this shows time trend in utilization of low intensity treatment for AML. If you see in 2018 and 19, this number was around 25%, but now around 56%, 50%, like half of the patient newly diagnosed AML in our country are receiving low intensity treatment, mainly comprising of combination of azacitidine with venetoclax. So very slowly, I say this revolution is coming in and people are silently using it. And because they are getting themselves convinced with this combination, the relative ease of administering it, having lesser mortality is a big deal for AML in our country. Now, towards the end of my presentation, till now I have shown you that venetoclax and azacitidine is emerging, or rather has emerged as a very, very usable option for AML induction. But still, many people in the world, in our country, may not be convinced. They will still say no intensive chemotherapy, and they are absolutely right in their own way. For them, I would want to bring this concept of venetoclax as maintenance therapy. Now, this was a study. um, they studied that reduced dose azacitidine plus venetoclax as maintenance therapy in AML patient following intensive or low intensity induction. It was a single center phase 2 trial, but this was the first trial which spoke about this, and corresponding author is Tapan Kaidia. He is from MD Anderson and he is working a lot on venetoclax. So they said that if you are not convinced and you still want to give intensive chemotherapy, you can bring in venetoclax as a maintenance therapy. The better designed study on maintenance venetoclax was Quasar AML 001 study, which is a randomized study in which patients were given either azacitidine or venetoclax maintenance in this dose, 14 days or 7 days. And there are two cohorts in this study. So you can see if the venetoclax was used in maintenance setting, then also patient of AML who had NPM1, IDH1, IDH2, they had a greatly improved relapse-free survival of 80% at 2 years, with no relapse occurring beyond 1 year of maintenance therapy. The other benefit was seen in patient who had ELN favorable risk of AML, again 2-year relapse-free survival of 75%. You can see these two are favorable and intermediate. But venetoclax maintenance could not help patient who had ELN unfavorable or high risk profile. Here also, if your patient has NPM1 or IDH1 or 2 mutation, you can see almost flat line with venetoclax maintenance. But if the patient did not have these mutation, then the line is dropping, and this remains an area of need. So as a maintenance therapy, again, here comes the difference with maintenance MRD negativity and MRD positivity. The patient who were treated with azaven maintenance and they were MRD negative, you can see even after 5 years, excellent flat curves. But those who were MRD positive, their survival, relapse-free survival, fell down precipitously. So I spoke in the beginning also that MRD negativity is emerging as a very important marker of outcome with AZA and VEN, both in frontline setting as well as in maintenance setting. This graph is in maintenance setting. So how can we integrate, AZA-VEN currently, especially in developing countries? It's something looks like this, that first you induce, then you check, then you consolidate. For inducing, induction with HMA plus low dose venetoclax with an azole seems to be a very practical and pragmatic strategy. After giving this therapy, you check and confirm that bone marrow is in remission or not. If your bone marrow is in remission, then you move towards consolidation, where there can be three possibilities. Number one, by just give a HIDEC-like combination, 3 or 4 cycle of HIDEC, and you complete the treatment. Second is you do a bone marrow transplant allogenic. Or third, you just continue AZA-VEN indefinitely, the way it was done in Wiley study. Now, at this point, we do not know that out of the 3 strategies shown on this column, which is going to be the best strategy? Only a properly conducted trial. First, we collect retrospective data in our country and try to answer this. And on the basis of that, we develop a prospective trial. Then only we will be able to answer that if we are using as-a-when in younger individuals, what is going to be the appropriate consolidation strategy to properly treat these young patients. Because if you are treating a 30-40-year-old AML, you can't give as-a-when indefinitely for next 20-30 years of his or her life. So therefore, we have to find an end point. Moving towards the future. Now, as-a-when, I firmly believe, will continue to be the backbone of AML induction, but a new partner X, will emerge. These are a few, abstract from like combination of as-a-when with gilteritinib, decitabine, venetoclax with quizartinib. And in the beginning, I showed you that both gilteritinib and quizartinib have synergistic action with venetoclax. So when it was used, you can see complete remission rate 100%. Again, composite complete remission rate 100%. These are very, very early phase concept finding study and small number of 7 patient and 27 patient. And excellent complete remission rate with a triplet. As we go forward, we will read more about the toxicity of a triplet agent because there will be significant interplay between interaction and toxicity if you use a triplet. But I'm just giving you a peep into the future in which direction are we moving. Another one which is more familiar is cladribine, venetoclax with Ara-C and cladribine. This trial has already been completed, and they also found that complete remission rate are around 80%. But again, the concerns are regarding toxicity. In this trial also, they showed the impressive role of MRD. The patient after clad and venetoclax who had negative MRD, flatline, blue graph, and the patient who remained MRD positive, a consistent decline in survival was noted. So combining venetoclax plus azacitidine and third axis T cell bispecific antibodies. Now in the field of hem-onc, we know myeloma and DLBCL bites are coming in a big way, so much so that they are challenging CAR T cell therapy. So this is the first glimpse that in AML also, bites are coming not alone in combination with AZA and VEN. The last thing is again same point which we always discuss that if you are treating a young patient with AZA-VEN, you can't give venetoclax lifelong like imatinib, like dasatinib. So people are talking, can we stop it? For this trial was done, which is TFR in AML after venetoclax-based therapy. In this, a subset of patients who received 1 year of venetoclax-based therapy and they were in durable CR, the risk of relapse, duration of relapse-free survival, and overall survival was similar to a cohort of patients who continued therapy until progression. This is so heartening to see that if you are having a population who has been in sustained CR with venetoclax for 1 year, in one cohort you stop it, which is like red one, the venetoclax was stopped, and blue one, venetoclax was continued. Again, this is early trial, only 29 patients, but you can see the outcomes were comparable, and the patient in whom venetoclax was stopped did not do worse. I will now conclude my trial by saying that HMA with venetoclax is very likely to become the backbone of all AML inductions. It is already a backbone for elderly or unfit patient for AML induction. But going forward, this will not be an overstatement if I say this combination is going to become a backbone for all AML induction, along with a third partner X, which can be anything, any molecule, FLT inhibitor, IDH inhibitor. It can be a bispecific cell. It can be a third drug like cladribine. Only time will tell us. The optimal dose and schedule of VEN for AML induction remains unknown. But I have shown you a reasonably good amount of evidence that lower doses of venetoclax as well as lesser number of days of venetoclax both are feasible and both are able to achieve remissions without compromising on efficacy. Rather, they were more safe, and in our Indian context, they were cheaper also. When is making a foray into the maintenance of AML also. So those patients who were given full 3+7 and for some reason BMT is not possible, then when can be a good drug as maintenance therapy, especially if they have NPM1 or IDH mutant AML. We need to find a better partner for azaven to deepen its effect and head towards cure. This is work in progress. For younger patient treated with azaven, we need to find a best post-remission strategy. So this remains a work in progress. As I say, the fight against AML is relentlessly on, and we will win it. With this, I thank you from my city and my institute, and I hand it over to the organizer, Dr. Amit and Dr. Seema.
Thank you, Dr. Gaurav Prakash. Wonderful lecture. I think you covered almost everything about venetoclax in AML, which is the best treatment and which group benefits a lot. The role of maintenance in venetoclax is again a big question mark now. We'll discuss in the question answer session. Thank you so much. And I now request all our discussants to please put the hand raise signs so that we can start our discussion with Dr. Gaurav Prakash. So, yes, Dr. Upendra Sharma, your question.
Thank you, Dr. Prakash, for that excellent talk and letting us how we can incorporate venetoclax in the treatment armamentarium of AML patients. So, in your presentation, you elaborated that venetoclax is not effective for those patients who are having FLT3, TP53 mutation, and RUNX1. So, those patients, so transplant ineligible elderly patient comes to you with TP53 mutation. So, what is your take? Single agent azacitidine or azacitidine plus venetoclax?
Yes, sir. Thank you for the questions. That is the most difficult to treat, and that is one subset TP53 mutant. And I will take TP53 first because we do not have any drug targeting TP53. We know gemtuzumab ozogamycin does not work in that. We know venetoclax works, but the outcomes are not as good. So the only thing we are left with is if the patient can tolerate systemic chemotherapy. If cannot tolerate, then anything between like hypomethylating agent, low dose RSE, or supportive care can be, the fit patient chemotherapy remains. Venetoclax may not be a very good idea in that cohort given the data that we have today. IDH1 mutant is a different thing because we have inhibitors for both IDH1 and 2. So in them, combination of some abbreviated chemotherapy with IDH1 or 2, enasidenib or ivosidenib, if patient can afford it, that combination will be the way forward.
So for those patients not fit for intensive therapy, you prefer single agent hypomethylating agent?
Single agent hypomethylating agent, or so venetoclax is actually what I showed that venetoclax is inferior in comparison to patient who had NPM1 mutation. So that graph is looking poor because you are comparing with NPN, which is a good risk AML. Now, if you see a TP53 mutant or say RUNX1 mutant, azaven versus aza alone, then combination will still be slightly higher. Although prospective trial will only show us that graph looked poor because we had a very good cohort of AML patient who were NPM1 positive, core binding factor. So therefore it was looking poor. But if we have only one patient who has TP53 mutation or complex cytogenetics, and I have to use between single agent HMA versus HMA-VEN, then needless to say, the choice will be combination of VEN and HMA.
Which HMA? Decitabine or azacitidine?
Azacitidine. Most of the data has been with azacitidine, and it can also be given subcutaneously. But then some of us are very comfortable with decitabine 5 days schedule and all. But there is no very good data to compare between the two.
Dr. Amit, can I ask a last question?
Yes, please go ahead.
So in your talk, in the last, you have very beautifully explained. So those patients who are young, fit for intensive therapy. So you have induction, you have told that HMA plus venetoclax. Then we consolidate those patients. So how do you treat those young fit patients, say 30-year male, no comorbidities, fit without any infection?
Yeah.
On the day one, he comes to you with
Yes.
a report of favorable risk cytogenetics. On first day, no infections, patient is physically fit. Do you prefer 3+7 or HMA plus venetoclax induction for these patients?
Yeah, perfect. I mean, this is a very important question and very difficult question to answer because if you go by today's data and our practices and our thought process, a patient of good risk AML are the one who harness maximum benefit from chemotherapy and RAC high-dec therapy. A completely neat and clean young patient, no comorbidity. Yeah, the standard treatment would be 3/7 with a high-dec consolidation because they also do not need a bone marrow transplant. But at the same time, we have also seen excellent flatline if you give Azaven and they achieve MRD negativity. Now, all of us have access to very good MRD tools across India. So if you have treated that patient with much lesser toxicity with one oral drug and only HMA, not giving dono, no cardiotoxicity, all those things. And after that, you get consolidated with HIDEC and maintain with Venetoclax. That is a very good strategy. What I want to say it forward that this remains in a research realm. I mean, in a Monday morning tomorrow, if there is such patient as you have described, it will be difficult for us to directly offer this, HMA when with the MRD negativity guided therapy. It has to be as a part of a research protocol as of now. But if I have any doubt regarding patient's ability to tolerate intensive chemotherapy at any age, or the patient lives say very far away and all those, or difficulty in admission, then I will not be hesitant. Since I have reviewed this data and we have been researching on this, I'm convinced that if there is a patient where we have even slightest of doubt regarding ability to tolerate, handle, or have the logistic to go undergo 3+7, we will not be hesitant in giving HMA when followed by subsequent consolidation, which in that slide showed you either BMT, HIDEC, or just maintenance as a win. And with NPM1 will not be BMT, so it will be HIDEC.
So tomorrow, Monday morning, you have a very clean patient.
Yes, yes.
So the 3+7.
It will be if everything you showed pink and rosy 3+7 followed by HIDEC will be standard. But if I have any slight doubt, I will with out of trial also I will be comfortable in treating with Azaven followed by HIDEC therapy as consolidation.
Thank you very much for that.
Thank you, Dr.
Thank you.
Thank you, Dr. Upendra. Dr. Asha Shah, ma'am, please go ahead. Dr. Asha Shah. Dr. Asha Shah. Okay. So Dr. Shweta Pathak.
Hello, am I audible, sir? Hello.
Yes, you're audible. Yeah, Dr.
Yeah,
Asha Shah is
yeah.
there. Yes, ma'am. Please go ahead.
Thank you, sir, for a very excellent presentation. My question was about Azavan plus a third agent, which you said can be added. That in the studies you showed either gilteritinib or cladribine and other agents. So, will that third agent, which is to be included, will be based on only the cytogenetics, like for example, FLT3 positive, or across other cytogenetics also?
No, ma'am. As you said, it will be on the basis of mutation profile because these are very specific, targeted drugs. So if you have FLT3, then you will use FLT3 inhibitors. If it is IDH1
I'm
and 2.
sorry, you're not audible.
He's
Hello.
audible. He's audible, ma'am, to us. Madam, can you hear us?
Dr. Asha Shah, can you hear us? I think we lost the link.
Okay, you can go ahead, Dr.
But I'll still answer her question. So clearly, it's like so. It's what I can say that it's like a BCR ABL mutation movement for us. In CML, the day we found BCR ABL, it changed the landscape. So now, since we are understanding genomics of AML better, all those targeted third agent is going to be specific mutation targeting drugs, and we are getting more and more of them. Challenge I see are in this strategy are twofolds. Number one is, all the studies, Wiley study showed that combination of azaven is sufficiently toxic, that it required interruption, cytopenias in FN. Now you think of a third agent, and any third agent in AML is going to be myelotoxic. So how those toxicity be handled in the day-to-day practice? That is challenge number one. And challenge number two is a perennial challenge for us is the cost of therapy of a triplet. Even as a when, if we go with the original when in full dose is costly. So a triplet with a third targeted agent, that is the second challenge.
True, very true. Thank you, Dr. Gaurav. Dr. Asha Shah, ma'am, do you have any other question?
Yeah, no, thank you.
Thank you, ma'am. Dr. Shweta Pathak, your question.
Yeah, thank you, sir. It was an excellent presentation. So I'm a pediatric oncologist, sir. So my most of the patients are like less than 14 years. So just wanted to share a experience of Vanessa. I have a 11-month-old baby. 3 years back, he had come with AML, diagnosis of AML. He was also a Down syndrome case. So we have given 3+7 induction, but he could not tolerate, even with the reduced doses he could not tolerate, so we switched over to Vanessa. So as you said, we also have given 14 days of Venetoclax and azacitidine, though giving Venetoclax was a real challenge, but still we could be able to give through crushing and then through NG. So somehow we gave the drug, and after 6 cycles of Vanessa, in fact after 2 cycles only, the child went into remission. So it's been 2 years of follow-up. The child, I mean, I have tried high deck also in that child after the 6 cycles of Vanessa, but still, even single dose of Citra he could not tolerate, and he went to the ICU. So then we thought we gave just go ahead with 2 more cycles of Vanessa. After, I think the child is been on follow from past 2 years, and he's doing well, absolutely well, and even the development is absolutely improving. So, I mean, my question is, I mean, should it, I mean, is there any experience of yours regarding treating such children of Down syndrome, small infant with Vanessa, like I had? Or
So,
any comment on treating these kind of kids with Vanessa upfront rather than starting with 3+7 induction? And I mean, because this child had very bad febrile neutropenia for 1 month, the child was in ICU. So next time, and I have one more Down syndrome. So for that child also, we have started with Vanessa. So I just wanted to know, is there anyone who's doing the same, or because it's just my experience, just wanted to know what is your comment on such cases, sir?
It is so heartening to see that the way you manage this patient and brought the child out of the clutches. And, so induction 3+7, patient was in ICU, then high deck again, ICU 1 month. So in ICU, you can lose a patient like in a moment's time. So therefore, this is the silver lining that we are finding with this combination of venetoclax and azacitidine, that the severe infection, although it is reported in violate trial, in day-to-day practice, it is seen less often. And one of the greatest reason behind it is that in India, almost across the board, most people are using low dose of venetoclax in combination with a CYP3 inhibitor. So I think the key lies there. Reducing the dose and days of venetoclax can significantly reduce myelotoxicity. What kills in AML early? It is mainly infection or myelotoxicity. Late, we can say that relapses and disease-related survival is a different story. But in first 90 or 100 days, the biggest reason of death in AML patient is actually infection. So if you can reduce your myelotoxicity or neutropenic or infection death, it is a great way. Second is a disclaimer that I only do adult hematology, so I have no experience of treating any child. I only remember from my training days that Down syndrome associated AML are relatively they have a better survival, more M7 type and all. So you will be a better judge on that. But then you opened up a gate. Your case gave us some insight into that this subset of patient may also do good. My personal experience is nil because I do not see pediatric patients. If any other speaker or expert has it will be very nice to share.
I have reported this child up. So just I wanted to know, is this the only case which I have treated, or anyone else treated in the same way?
Okay. So it as a inquisitiveness coming to me is like, can you answer what is the genetic NGS profile of this child and what dose of venetoclax you used?
Yeah, so it was very, I mean, initially for first cycle, child was very, very sick. So we just gave 50 mg. So the tablet comes as 100 mg. So we made it half and crushed, and the child was so small that he cannot even ingulf that drug. So we had to give through NG. That was
Okay.
also not a routine practice, but I had discussed with many of the senior and experts in this field. So they said, yes, this also can be done. So nobody has tried in my, I mean, group also. None of the pediatric oncologists have tried like this. But 50 mg initially for first 7 days in first cycle, and and then subsequently we went ahead for 100 mg. And the child, they were very poor. So somehow they could be able to afford 1 or 2 boxes. So what we did in subsequent cycle, we just continued 100 mg OD of Venetoclax for 14 days, first 14 days. So one box,
Amazing.
yes. This is how we have treated the child for
I
first 6.
insist that if you get an opportunity that you present this case on some forum, maybe you can write it up, because
Yeah,
not why this will help a large number of individual and for pediatrics, I think one big advantage is that even a small amount of dose can be arranged, even those who are not fully affording. They,
Hmm.
so that is, and this you gave, if you read, okay, this is a touchy point. Most of the time, that's our training has been that we have been trying to ape Western practices. And if Western people write that you cannot break this drug, you cannot give
Hmm.
this dose, and we will be like kind of, handcuffed. Okay, because it is written there, you can't do it. But then
Correct.
the patient are ours, the problem are ours, the situation is ours. So we have to find solution which is practical here. And since when you were up against between the rock and the hard place, and you gave a drug after crushing, and also you showed sustained 2 year remission, that is very, very heartening. I cannot say that this is a treatment, this should be the treatment, but this experience can be a gateway to further research and establish this thing.
Thank you, sir. In fact, that high tech idea was also given by one of the very senior person in the forum. They said, "I think this is not enough, Dr. Shweta. You have to try with one more high tech." And then once I started high tech, he again went into the ice. Then I didn't try it again. So therefore, I mean, this is one of the best experience I've ever had in treating such AML kids. And definitely, I look after the people who are interested in doing the same thing in small infant.
If you can reach out to me, then I think we can work on this and develop something if you are interested in that.
Yeah, definitely, sir.
Okay.
I'm very much interested.
Thank
Yeah.
you, Shweta.
Thank
Yeah.
you. Thank you, sir. Thank you.
Thank you, Dr. Shweta Pathak. Dr. Avinash Singh, your question.
So nice talk, Dr. Gaurav.
Thank
So
you, Dr. Manish.
yes, my question is that when on patient on Azaven, when to say that it's not working, and if suppose it's not working, then what protocol we should follow next?
Uh, so, um, so, very important question. But before this question, another question comes always, which is like, if you are giving as a when will you do a check bone marrow? Which is almost like same situation. So, if like I have a privilege that I work in an academic research institute, so here we have a very clear thought that if whatever induction we give, at day 28 we do a check marrow and see what is the real situation. But in practice, or where doing repeated marrows and MRD are not easily available, then I think if you have given induction 4 weeks of therapy, patient is relatively okay and counts have recovered. So how do you say, like 40, you give 42 days from the day zero, day one of first cycle. So after, if your counts are up by day 42, you start the second cycle. If you are not sure of patient's overall remission status, and you can do a marrow after second cycle also and third cycle also. The earlier idea is because venetoclax promotes apoptosis. It is not blast cell lysis the way chemotherapy does. So it may take longer for venetoclax and hypomethylating agent as a cytidine to bring in remission. This was hypothesis and understandable because one is hypomethylating agent, again a epigenetic drug. The other is venetoclax, which is apoptotic drug, not a complete cytolytic drug. But then the data from published studies and our own experience shows that CR rate is around 60 to 65, 67%. And in good risk individual, CR rates are up to 80% after one cycle. So therefore, we are convinced that if you can do check marrow at the end of first cycle of ESA-VEN, it will give you good information. Now, when will we call it a failure? It is a difficult question to answer. At least 3 months is something. If having given it and the patient is not in remission, then we probably say that this combination may not work. This is completely on a gut feeling. And after that, it is the same story. If the patient is fit and can take 3+7, that is the only option you will have, because those who are not in remission with azaven, are unlikely to undergo remission only with azacitidine or decitabine. What other drugs do we have? It is an open situation. So I hope I answered your question.
Thank you, Dr. Gaurav. And another question is, so if suppose we have option of Flagven and Azaven, then any advantage
Yeah.
of Flagven?
So Flagman is a MD Anderson data which is coming up, and it is the same story. When Americans will do and publish it, then we will accept it, and before that we will look at everything with a big amount of doubts. So as I started my presentation, I said main issue is that most of there is data published. Dr. Chapsy Philip from CMC Vellore has published that out of 100 patients which come to their center, only 30 patients receive intensive chemotherapy. 70% either go home because they come from far off, cannot afford, or cannot tolerate. So the harsh reality is that we are talking only about 30% and focusing on 30%. We have left the, or God's own child, 70%. So the problem started that when 3+7 we are able to deliver only to 30% of our patient in Indian AML patient, then flag when you can just imagine flag in combination with when the cytopenia. So I always say that we have to have a look. We have to have a protocol, at least induction protocol, which can give at least to 50 to 60% of the individuals. So the debate is not between flagven and azaven. It is the approach. I will always say that if I can treat 20% patient with flagven, but 60% of my patients with azaven and have comparable remission rate, then azaven should be my go-to combination for AML induction therapy. Dr. Upendra Sharma asked in the beginning, gave a very difficult case. Everything is fit and fine, affording, young 30-year-old. Obviously, 3+7 or flagven will be a preferred regimen for those kind of patients, but they will be far and few in between. A vast body of our patients will not be eligible for that combination. So therefore, I see more merit in having azaven. And if we can sharpen our skills in using azaven in a better way rather than imitating flagven, that is my personal thought. And all of this has to be substantiated by further research, and which can only be possible by collaboration by you and everyone else. So that is my viewpoint.
Thank you. Thank you very much, Dr. Gaurav. Thank you.
Thank you, Dr. Avinash Singh. Dr. Upendra Sharma, you have any other question?
So yes, Dr. Gaurav. So I think for those young fit patient, 1 or 2 dose, because giving 3+7 and having mortality with 3+7, you feel very bad.
Absolutely.
And you see that if I have given as I went to this patient would have survived. So best way, I think it can be 1 or 2 cycles of azaven. You see the cytogenetics, favorable risk. If patient is having favorable risk, yes, you are that protocol. Then you see the patient is then fit, eligible, 3 high dose cytarabine. Yeah, I think mortality rate will be very, very less for these patients. 1 or 2 cycles of azaven, then consolidate with 3 cycles of high dose cytarabine. Skip 3+7, induction with azaven, and 3 cycles of high dose cytarabine. I think so. Mortality will be very, very less for these patients. Even if patient is very fit, chance of getting a mortality with 3+7 is very high as compared to azaven.
Absolutely, Dr. Upendra. I will, in the same breath, I will say that when we see Western results with therapies, very intensive therapies like FLAG-IDA, FLAG-VEN, or other intensive AML chemotherapies, we never consider the fact that these studies were done where there is no NDM1, where there is no carbapenemase producing Klebsiella, where there is no invasive aspergillosis or those infections, the way we handle them. So this part is conveniently forgotten, and what we focus on, that CR rate is this much in this regimen, CR rate is this much, that is important, no doubt. But then, as you said, if you are losing even say 10% of the patient because of these infection, because you use very intensive, by reading a Western paper which was conducted in a Western hemisphere in a much less community or hospital acquired infection rate. So that is where the balancing act has to come. These are thought processes, but obviously answer is going to come through a well conducted trial. But my argument always remains that till the time we do not have that well conducted trial, do we not have evidence enough to treat more patient with a combination which is more forgiving, which is easier? Second, FDA has given approval to Venetoclax and HMA on the basis of phase 1 trial. So once FDA has given, we are all very happy. We will use it because FDA have done it. So, but if we, on the basis of phase 1, if we change our practice, or phase 3, we have Wiley data, then people say, no, you have to conduct a RCT with 3+7, and that is something which baffles me sometime. Somewhere we have to be very pragmatic also in our approach, and naturally it should not be an excuse of not doing research on this topic. But by that time, we can at least develop a way of utilizing this combination in a better way for those patients who are at borderline of fitness, at least.
Last few months, last year, I'm a bit reluctant using 3+7 because for few of those patients who have died of 3+7,
Yes, they do.
at the end of the night, I think that should I have given 3+7 to this, should I have given Azavan to this patient? This
So
patient would have survived.
just
So
to
I think I have
substantiate,
killed that patient on that 3+7. So I have a better option, and then we can consult with hydroxychloroquine. So I think so then this is a very good strategy. And one of the question was there for Down syndrome. For patient with Down syndrome, these patients, just like Fanconi's anemia, these patients, they have a fragile chromosome. So they are not fit for very intensive chemotherapy. So these patients, they do better. I have few patients with Down syndrome, 2 or 3 patients treated with Down syndrome.
okay.
So not intensive chemotherapy is eligible for these patients. Cytarabine, etoposide, those combinations, there are some protocols. So
Okay.
when you do treat those patients with 3 to 4 cycles of that protocol, and these patients, they have an excellent prognosis as compared to Down syndrome. This patient, they have good prognosis compared to other
Relatively
patients.
low. Yeah, yeah.
So these patients you treat just like Fanconi, wherein they are very fragile patients and very sensitive to chemotherapy. Low dose chemotherapy is very sensitive, and cure rate is very excellent for these patients.
Mhm. Thank you. Thank you for the input. And I think if Dr. Shweta is on the call, she will be taking this.
Yeah. I was listening to sir. Yeah,
Okay.
thank you, sir. Thank you very much, sir.
Dr. Shweta, you can see the literature that yes, these patients, they are really not fit for intensive chemotherapy. It is not a good idea to give 3+7 or hydroxychloroquine to these patients because they
Yeah,
will not tolerate these chemotherapy therapeutic agents, and mortality is very high. So
yeah.
they have some protocols using cytarabine, etoposide, and anthracene, not a good option for these patients.
Mm-hmm. No, I went through that, sir, and that girl only received 2 doses of cytarabine. And initially, I started with just 30% of the usual dose because van as a sir, I'm working in a government hospital where there is no access to van and all these fancy drugs. So that also we could be able to arrange with the help of an NGO. So you could imagine that rather than doing nothing, we had to do something. And that's when I mean somehow one person came like a god to us, and then he brought the Venetoclax for that child. So that was the reason I could not start with the Vanessa upfront. So,
But
but somehow child had to survive, and then everything happened.
so there is
So
not
yeah.
much of data with Venetoclax in the Down syndrome patients, and I have not had
Mm-hmm.
that personal experience also. But few of those patients with low intensity chemotherapy, they have done excellent, and they are in remission now.
Yeah, now I have 2 patients, sir. One more child just finished his 6th cycle of ANESA. So I just did MRD day before yesterday. That report is awaited, but previous after first cycle, the MRD was negative. So I think this is really doing wonderful. So if people who are treating with ANESA upfront Down syndrome with AML in a small infant, this could be a very good, study, multicentric study.
Thank you for that input.
Thank you, sir. Thank you, sir.
Thank you, Dr. Shweta Pathak. So we have got a few questions from the audience. There's a question from Dr. Kannan. Is there any group of patients where you have to give 3+7, must to give?
Yeah, so it is extension of what Dr. Upendra Sharma just asked. So definitely, if like tomorrow morning, if you have a patient who is young, fit, no comorbidities, especially affording also and can be treated in house, then definitely if the standard treatment would again be 3+7, and you induce, if you achieve remission, you give a post remission consolidation according to the genetic risk profile. That remains standard. Azavan has not yet replaced intensive chemotherapy. What we are saying, in a given circumstances and scenario, or with the incidence of infection, especially severe gram-negative infection and fungal infection, for our country, we need a different approach. And AZA-VEN combination can hit that sweet spot where this can emerge as a preferred induction strategy even for young and fit. The various groups are working on this. As of now, to say dogmatically that 3+7 intensive chemotherapy is not required and this combination has arrived will be an premature statement. But if you have a patient and you are aware of a flora of your hospital where the incidence of if resistant bug is very high, if the fungal infection incidence is high because of whatever construction and all reason, then you are very well justified in giving a protocol of induction like this, and you can always go on to give HIDEC and allogenic transplant later on also. Because see, on day one, AML is the most susceptible. They are cytopenic, they are immunosuppressed, they are neutropenic. Now, imagine that situation you have given AZA-VEN, 1 month they are in remission, even if partial, their counts will be up, platelets are likely to be up. In that situation, they will be able to tolerate HIDEC, 3-7, whatever, in a better way. So this is a practical, pragmatic approach. And to say radically that there is no role of 3+7 at all, or there is only AZA-VEN, we are a bit early to say that.
True. There's one question from Dr. Sfilu 10. Do we need to ramp up the dose of Venetoclax or straight away
Yeah. Yeah, so it is like a ramp up dose like in CLL. So two things, because BCL2 is not a driver abnormality in AML. So TLS is not as severe as in CLL. But if you read Wiley data, biochemicals TLS happened in 18%, but the clinically frank TLS leading to kidney failure and all was very less, 1 to 2% patient had it. So these patients do have TLS, which is mainly biochemical, not that severe. So therefore, ramp up is needed. And why should we be afraid of ramp up? It is only 3 days. First day 100 mg, second day 200 mg, third day 400 mg, and then continue. So answer is yes. Ramp up. Why should we avoid ramp up for a drug which we are going to give for longer duration?
Absolutely. There is one more question from Dr. Shyam. Do you agree in the recent paradigm trial of VEN plus EZA versus intensive chemotherapy in fit patient showed better EFS, low infections, and low mortality with EZA-VEN? Is it true? And second thing, do you still feel that intensive chemotherapy is going to stay here for induction?
Yeah. So again, by my presentation, you might have sensed that I am almost convinced, but that is as far as my practice is concerned. To preach that you go tomorrow and leave everything and start 3+7 will need some more time. We need to see a longish follow-up of these data. Even if you see the AML phase 3, the AZA-VEN phase 3 data, over last 5 years, the graph has trickled down. That means the patient who were treated with AZA-VEN, somewhere down, even down the line, they are relapsing. So to say that AZA-VEN has arrived and completely replaced, again, it is premature statement. The trial that you have mentioned is, going to answer it, but then we have to wait for more follow-up. At PGI, we have a primary policy of thinking, giving AZA-VEN even to young and fit individuals. Yes, very small cohort who have kind of good affordability and ability to withstand infection, they may receive 3+7. And what we have observed is similar. Our requirement of blood products, our requirements of prolonged antibiotics have come down significantly, and we have not compromised on complete remission rates. So that is one. What was the second question here?
Same thing. Do you still feel the intensive chemotherapy is going to stay here for induction?
It is okay, going to stay here. I think it will be replaced. But is it tomorrow? Answer is no. But how soon? Let us wait.
Absolutely. Another question from Dr. Priyanka. Elderly patient who is AML, IDH1 mutation positive, became MRD negative post 6 cycles of AZA-VEN. Can we give only VEN maintenance? And if so, how frequently? 14 days in 2 months, 7 days in 2 months, or you prefer AZA-VEN maintenance 2 monthly?
Yeah. So we don't have answer to that which is going to be a better strategy. First of all, what we are, not we means the word is trying to answer whether maintenance is helpful or not. In the trial, in the Quartz AML 001 trial, which I showed, what they gave azacitidine for 5 days and venetoclax for 7 and 14 days. Two arms were there. So definitely you are going to use venetoclax for a shorter duration. I just want to highlight here that venetoclax has long half-life. That is one good thing about this drug, and it is highly protein bound. So therefore, even if you are giving it for say 14 days, the effect of drug is going to be there in the system for at least 21 to 24 days because of long half-life. So we do not know the right answer. That is the honest answer of this, that which maintenance is. First, we will establish that when as a maintenance is beneficial, the initial data says so. Then we will try to dissect that which maintenance protocol is better than the other. Now, given your patient, if I were the treating doctor, I would give maintenance with oral azacitidine and oral venetoclax for how long duration, depending on case to case.
So venetoclax monotherapy is not advisable as maintenance.
Yes. Why? Because the monotherapy in AML was a very inferior trial initially. So we learned from CLL. Monotherapy was excellent drug, yeah, for CLL, venetoclax. So we said, okay, fine, let's do the same for AML. But in AML, it was not a success. So therefore, something which did not work in initial cytoreduction or therapy, I will not be using monotherapy just on the basis of what we learned from the early initial induction therapy.
So venetoclax mono has got no role. It has to be always in combination as maintenance.
For AML. For AML. Yeah.
AML. That was similar question has been asked by Dr. Yimon Tent. Can we go with only when after as a when? So we answered no. It has to be with as a when as maintenance.
No,
What
combination.
about high deck? Can we go for as a when maintenance after high deck 3 cycles?
Yes, this is exactly what was done in that trial. They gave intensive induction, maybe high deck 1 cycle. Again, so all the panelists will agree with me that all those are unanswered question, because no, there is no trial data that after high deck maintenance with azaven. Right now, the world is grappling to have when more in induction protocol. So the ongoing trial on maintenance is like induction therapy. You gave maybe one or few high decks, and after that you gave induction, say for 1 year. I show you when stop trial. So at least 1 year of maintenance after that when they stopped. That trial was only a 28 patient, but in 28 also they showed that the outcomes are not different. So what I can tell you with the data I reviewed and I have studied is that if you are giving vein maintenance, try to give in combination with azacitidine, and after 2 years of sustained remission, you can probably think about stopping it because it is costly drug, it is toxic drug. So that is something we can infer. It cannot be said dogmatically that this protocol is going to be better than the other. That can only be answered with a randomized trial.
True. Thank you so much. Dr. Avinash Singh has a question for AML with IDH1 mutation positive. Is ESA IVO better or ESA when better?
No, triplet. It is going to be triplet. IDH mutant. So IDH is a driver mutation and it is a poor risk marker. But both ivosidenib and
For the upfront.
upfront, yeah, and venetoclax have better outcome. Those patients who have IDH 1 or 2 mutation, when they are treated with venetoclax, they have better survival, a better response rate. So I will definitely bring in venetoclax. Now, second, we have a targetable mutation. If patient can affording, I will bring in the IDH inhibitor. Now, since we know that when work better when in combination with HMA, it is going to be triplet, and triplet trials are ongoing, and we have to wait for answers from those trials that what is the exact efficacy and toxicity.
Fantastic. And if it was elderly AML with IDH1 mutation positive, ESA when or ESA IVO?
Same difficult. So I think induction with as a when. Elderly patient, when younger patient also sometimes struggle with higher dose, low dose when with the azacitidine, and then from second cycle onwards you can add. I will bring in one corollary. Those who I think most hemato-oncologists also treat DLBCL. Going forward, you will see DLBCL trial in such a way that first cycle was given R-CHOP. And after first cycle, when genetic report came, NGS or gene expression profiling, any newer agent will be added into that. So first cycle you give, it is doublet is more better tolerable, more forgiving, less toxicity. It will reduce burden, and then you can bring in your target. Patient need time and money to arrange for newer drugs. So first you can start with this and add third agent later on in a given case. That is how we treat. I'm just sharing you our practices here because these are questions which are still unanswered.
So for elderly patient, AML IDH1 mutation positive as a when way to go other than
Way to go with, and if the
Yes,
patient can afford, you bring in IDH2 inhibitor. It will deepen the trial with triplet have shown faster and deeper response. CR rate was 80%, 80 to 100% CR rate in newly diagnosed in that small trial which I showed. If you can show, so no doubt you are using three agents. What I said in the beginning also, we are because of those trial are very short, small number of patient concept finding trials. We do not know the toxicity profile of those, how toxic a triplet will be, because IDH mutant are also myelotoxic. When is myelotoxic? ASA is myelotoxic. So that remains an issue. Before we just jump, we heard in the webinar that triplet has a 100% CR rate. An old patient with AML may not tolerate that triplet. So therefore, how I will treat it is like I start first cycle with azaven. It will reduce the burden. Patient will be in a better shape, and then we may probably in a given case to case basis we can add IDH inhibitor.
Thank you. Another question from Dr. Seema Bhatwadekar. Does your Ven dose change with the bone marrow cellularity?
Ma'am, my Ven dose changes with the CBC counts. If the patient is there is incomplete recovery, then I will not hesitate in going down on Venetoclax dose, especially when the patient has been induced and bone marrow is remission. Because since you have done bone marrow, you know the blast count. If the patient is in remission, but the bone marrow is hypocellular, I'll wait for the counts to come up. At that point, I will do GCSF. So, one of the trial design has been that you give azaven. On day 21, you do marrow. If the marrow does not show excess blast, you start growth factor. Because if you are using full dose Ven, it is going to be myelotoxic. So on day 22, you start growth factor. By day 28 or day 30, your counts are up and you can give next cycle. So
Question is ki when many times it happens that MDS patient going into AML, at diagnosis only they have a somewhat hypocellular marrow with the blast. In such patients, will you go with the lower dose of means this even your 50 as a 50 when with POSA is going to be means it's means there are reports and data which shows that 50 when you add POSA their concentration is 8 times higher means it's equivalent to 400. So will you give when in such cases without POSA just to maintain the lower concentration of the vein?
Right. So for MDS related AML, generally we find when we do marrow, we find hypercellular marrow. But then sometimes hypoplastic MDS
Sometimes
are
you
there.
get the pancytopenia, and to your surprise, you get I mean, usually with pancytopenia, we get a packed marrow, and ALL is usually diagnosis. But sometimes we get a AML, hypocellularity, and there are blasts.
Yes, it does. Yeah, hypoplastic
So
MDS leading to is a situation.
AML blast. Then in that situation,
Yeah.
what I feel is just go with the ESA, see the cellularity and the count, and then we can add vein later. Is my approach. I just
Absolutely.
wanted your approach.
Yes, I will agree with you that if you feel that the patient's condition in a given patient's condition, if a combination and the resultant cytopenia with that combination is going to be more detrimental, then starting first cycle with even abbreviated as a cytidine, say only 5 days of
Yes.
or 3 days of Deceta, you bring down the packed marrow situation and give more space in marrow for hematopoiesis, and after that you give azaven. These are the skills. That is why hematology is such a difficult branch that we have to impart our skill apart from data also. So
Yes, yes. Because
absolutely,
all
madam.
the patients are different. You every day face a different challenge. Even though you feel that
Absolutely.
Azaven is more comfortable than 7-3, but as you mentioned very correctly, even though it is a comfortable compared to 7.3, it is still myelotoxic, and we should be very careful
We
using
should be
all
very
these
careful.
elements. And it was a really great presentation, and all the all the aspects of when you have actually covered very well. Thank you so much.
Thank you very much.
Thank you, ma'am. Another question is from Dr. Nasrin Shumi. BCR ABL positive AML, major transcript, with no antecedent history of CML, not suitable for intensive induction, received EZA plus VEN plus dasatinib, started as induction and after 2 cycles, MRD became negative. What would be the best next approach for this patient and how long to continue dasatinib?
Again, I like the previous Down syndrome case, very heartening to see Dr. Shumi this thing. Although you are in the driver's seat, but whatever you have written, my hunch is that we are dealing with a CML with myeloid blast crisis. So therefore, our approach should be on those lines, and this patient should be offered an allogenic transplant at this moment. And post-transplant patient can be on TKI maintenance therapy. That would be my way of treating this. Now, if for any reason transplant is not possible, then you continue because in only 2 cycles, MRD negativity shows that this patient is likely to do better than other patients, but then the continuation of same therapy as a when with dasatinib.
Perfect. Another question is from Dr. Shyam. In a young fit AML patient with TP53 mutation positive, no infection, no comorbidity, what is your treatment approach?
Young AML, TP53 positive, mutation positive, and
no infection, no comorbidity. So what is the treatment approach?
Yeah, I have no doubt. In this patient, in this kind of patient, you give cytotoxic chemotherapy, find a match. If not match, then haplo, do BMT.
Perfect. Another question is from Dr. A.K. Ganju, sir. Any role of any role of adding of triplet therapy in APML? If yes, then when? In APML.
In APML, okay. Good morning, good noon, sir. So APML, actually, we already have a recipe which is working very well.
It's about adding venetoclax in APML.
No. So, no, sir. First of all, I have to go back and check whether promyelocyte also have equal expression of BCL2 or not. But then we have a recipe which is working very well for APL already. So maybe if at all I will use will be in cases with either refractory or relapse APL, not in upfront. Although I would want to educate myself and see the expression of BCL2 on APL blast, because in AML it is very well known that they have BCL2 expression.
Absolutely. Another question from Dr. Raghvendra Rajesh Workar. Any role of quadruplet, 3+7 plus EZA plus VEN?
No. So if you are giving cytarabine and azacitidine, so it's like one is epigenetic and other is genetic integrating into it, but they have similar kind of profile. And this quadruplet is going to be very toxic. So why would you want to give HMA when you're giving 3+7? Yes, 3+7 plus venetoclax can see the light of the day because on the line of MD Anderson flag Venn protocol, it can be something. I do not know whether, but quadruplet will very difficult. I will be very surprised if a quadruplet comes in this field.
True. Another question is again from Dr. Raghvendra Rajesh Workar. Why resistant mutations are studied only in CML and not in AML?
Why?
Why all the resistant mutations are studied only in chronic myeloid leukemia and not in acute myeloid leukemia?
Okay, because there we have a classical driver translocation BCR-ABL hybrid gene where there is a kinase binding domain, and any small mutation can render your drug ineffective. Whatever drugs I am telling you, they do not, except the classical FLT3 inhibitor and IDH inhibitor. These are modifiers, like BCL2 is inhibited, and after that, after multiple cascades, it has its effects on apoptosis and all. So therefore, there is no single identifiable change. That is the reason. Otherwise, we have a kinase domain very well defined and mapped, sequenced kinase domain sequence. So therefore, finding a mutation is easier. I showed you the mechanism of action, but I showed you the just basic of it. We still do not know how that downstream apoptosis. Apoptosis is one of the most difficult topic and open to research.
True. Thank you. Another question again from Dr. Ganju sir. As what Dr. Seema madam said that regarding the patients who are hypoplastic MDS with more number of blast, if we just drop out the posaconazole part, then we are giving only the half tablet of venetoclax, half 100 mg. That becomes 50 milligram. So that 50 milligram, to make it as 50 milligram, best is not to add posaconazole. Then it will 50 milligram.
Yeah, yes, sir. So PK studies are very well there, and they have clearly shown that with posaconazole and voriconazole, the level will be many folds. Our experiment on PK and PGI showed that even lower exposure, lower area under curve, lower AUC 0.24 was effective. So it can only be answered once we do a small phase 1 of a early phase 2 a trial with small number of patients by giving only venetoclax without a CYP inhibitor or a mild CYP inhibitor like ciprofloxacin or ketoconazole, something like that, which is milder than posaconazole, and demonstrate by PK. I mean, I cannot answer that it will be, we should do it. Since we have developed the PK facility in our in-house in our hospital, then your question gives me an idea that we can explore the possibility of giving only these things, especially in patients who are uh, the kind you showed. But at the same time, you will agree that most of our patients will need antifungals. So it is like a win-win. We are using either Vori or POSA to kill fungus as well as to reduce our dose of venetoclax. So to do away with posaconazole and bring in another antifungal in the form of liposomal amphotericin, because you have to give antifungal anyway. So I don't see a clinical situation where we would want to change antifungal to amphotericin B and only give venetoclax except under a research protocol where I really want to see the pharmacokinetic of naked venetoclax in Indian patients.
True. Thank you. Another question is from Dr. Yi Mathu. Any role of adding venetoclax in children with AML with 3+7 induction chemotherapy?
I will stop myself from answering this because, as in my disclaimer, last child I treated was in my DM 15 years ago, so I have no experience of treating children.
No issues. Another question from Dr. Umaira Nazneen. For the patient of AML who is both NPM1 and IDH1 mutation positive, will you go all the three as I when ivosidenib, all three together?
Yeah. Yes. If available and a patient can afford and tolerating, I will use triplet. Data is emerging, and if the patient can take it and you can handle the drugs, then you should do it. The newer molecules are also always tricky, more cytopenic and more cardiac toxicities, especially quizartinib and all. So we have to be really careful.
I think the better would be to start with azaven and then add on
Yeah.
ivosidenib.
As said previously.
Yeah. Dr. Yimon10 wants to know doses of venetoclax with different azoles prophylaxis.
Okay, so maximum CYP3 inhibition is seen with posaconazole. Number 2 is voriconazole and ketoconazole. Number 3 is a weaker one. So ketoconazole anyway is out because it is not used for mold prophylaxis. So we are left with 2. If you are using venetoclax in combination with posaconazole, the recommended dose is between 50 to 780. There are different reports. Our data suggests that 50 is good. If you are using with voriconazole, then 100 mg.
Perfect. Another question is from Dr. Raghvendra Rajesh Varkar. Any other chemotherapy combinations do have the similar efficacy as 3+7 induction or flag IDA based induction? Any other apart from this? 3+7 or
So
flag?
we have, okay, I got the question.
All three, let us take it out. Any other we can use in induction?
Yeah. So ADE protocol is there, etoposide. Although etoposide, ADE was mainly used in pediatric population, and there is no randomized clear head-to-end data, but that is one where it showed efficacy. So in adults classical, it is 3-7 or flag IDA or flag dono. and AD protocol, Aracid, Daunorubicin, and etoposide, which is more used in pediatric protocol, which can be used as an induction regimen.
Thank you. I think one more protocol has come, that is MACE protocol, if I'm not wrong. That
Which
is
protocol
mitogen
name?
is MACE, MEC. I think that was one publication had come regarding frontline use of MACE protocol.
Achha, okay.
So I think that is with the use of mitozendron actually.
Mitozendron, okay. So maybe in a cardiac high-risk patient, you can probably, you would want to avoid dono. Mitozendron is slightly less cardiotoxic, and epirubicin is also.
Perfect. So I finished all the questions from the chat box. Any other discussion? Want to ask any other question? Well, so I think Dr. Gaurav, we have bothered you a lot today with all so many questions today. And since last 1.5 years, you'll be answering all our questions. Thank you so much for the brilliant lecture, wonderful case discussions, and what a superb discussion we had with you today. Thank you so much.
Thank you so much, especially to you and all other panelists who interacted and gave and shared their experiences. I would just want to say that we all are learning. I just have got some opportunity of having researched in this area, so I read slightly more. Apart from otherwise, I am in the same learning boat as all of us are. Even to all the fellows who attended, I am saying the same thing. For a disease as formidable as AML, we need to come together, join hands, and try to answer these simple questions. And you all will agree with me that no Western organization is going to answer these questions because they do not face these problems. So that is one thing I just want to say. And it's not that I am kind of some dogmatic expert on this. Just this is a very open field. This field is molting at present. What shape will it take? Only time will tell us. But then keeping these in interaction and discussion on is one of the very important part, which thanks to MHG, which is doing it excellently. And with this, I say thanks and conclude.
Thank you so much. And I also thank all our discussants over here and the delegates who participate in this webinar, and meet you next week, Saturday, Sunday. And before we do that, Mr. Sumit Kumar Madan, please go for final vote of thanks.
Thank you, sir. Thank you.
So thank you, Dr. Gaurav Prakash, for sparing your valuable time on this Sunday. And it was a very lucid and wonderful presentation. And we have many key takeaways from this presentation. And your session was followed by a very, very engaging discussion. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Seema Bhatwadekar, all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating this entire webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you so much, everyone. Have a wonderful Sunday.
Thank you. Thanks a lot.
Thank you.